Okay, we are today. Hopefully, you're all here for Parenting Traumatized Infants and Toddlers Myths versus Facts for 0 to 5. Our presenter today is Dr. Michael Gomez. I'm happy to say is a returning Caltrin presenter. So, if you've been to a Caltrin training presented by Dr. Gomez before, can you let me know with an emoji? Anybody already seen Dr. Gomez, or is this a first time for everybody? Looks like maybe a couple of emojis. Great. Yep, I'm seeing a few. Good. So for those of you for whom it's a first time, we are going to tell you just a little bit about him. Michael, you can go to the next slide while you watch all of this participation and engagement come in, which is really cool. So Dr. Michael Gomez has been a clinical instructor at Bradley Hospital Lifespan Institute, which is a teaching hospital for the Warren Alpert Medical School at Brown University. He was also previously director of the Adversity and Resilience Community Center, which is a child trauma behavioral health clinic in Texas, where he was also an adjunct professor at Texas Tech University, Texas Tech University College of Education, and the School of Nursing. He was also previously faculty at the Center on Child Abuse and Neglect and the Child Studies Center Department of Developmental and Behavioral Pediatrics at the Oklahoma University Health and Sciences Center. Dr. Gomez specializes in trauma-focused CBT, treatment of adolescents with problematic sexual behaviors, PCIT, target, and assessment of autism spectrum disorders. He's a nationally certified TF-CBT trainer and a nationally certified CCERT trainer, which is a model for addressing burnout and vicarious trauma in providers. He's actually going to tell us a little bit more about that later. He is a co-founder for the National Child Traumatic Stress Network's Trauma and Intellectual and Developmental Disabilities Work Group. As always, I know Dr. Gomez is going to cover a lot of ground in 2 very short hours. So I'm going to turn it over to you to get started.
All right. Well, thank you, Dana, very much. Folks, I will intentionally go on and off screen for part of this, but I will try to keep the slides up as much as possible. But just wanted to be able to see me. Because I'm the guy that's going to be, for 2 hours. And I wish Dana could do my intro just everywhere I go because it sounds like, man, he knows his stuff. And I'm like, oh, crap, that's me. Like I'm the actual guy she's talking about. Yes, I, do a lot of work with trauma, autism, things like problematic sexual behaviors, treatment of problematic sexual behaviors. I was formerly at a place called Bradley, which is Warren Alpert School, Brown University's medical school. It's a teaching hospital. Sorry, I am Brown. I was at a university, but it's the actual place in New England. So what we're going to be talking about today is our littles, which are very near and dear to my heart. And so some of this will apply to the kids that are older, but we're going to try to keep it to that 0 to 5 range. Um, if the reason the slides will be sent out to you is because you don't have to remember anything I say. Okay. Uh, I would never torture you with that. But I'll try to keep the slides up as much as possible. There are many times I'll be coming on and off intentionally, and sometimes to show resources, sometimes just to talk to you directly. So don't feel like you have to write frenetically as we're doing this. Kimberly Boomer Sooner, glad to see another Sooner in the crowd there. So near and dear to heart, the Oklahomans. So that's me. I do this, and today we're going to talk about this. And like Dana said, feel free to use the chat box. I will try to keep an eye on that and answer them as they come in. But again, the slide material will be sent to you. So we're going to talk about our littles and a lot of the myths versus the facts there. And so I want you to look at the Kawakas because we're about to talk about all the horrible things that can happen to a child. But before we do that, look at these little guys. Aren't they like adorable? Don't they look like they exist on a diet of peanut butter and hugs? I mean, look how precious they are. I have spent way too much time Googling how to smuggle a Kawaka into the US. And so if you ever find out that I've been arrested, there's a 99% probability that's because I tried to smuggle a Kawaka into the United States. And so apparently it's highly, highly illegal. Okay, just trust it. I've done the work. Trust me, it's very illegal. Okay. But like there's little adorable little guys. So we're just gonna talk about that for 2 seconds before we jump into all the horrific things that could happen to children. Okay. We have 3 goals for today. The goals are I want you to learn some of the impacts of trauma for this population. The second thing is the term trauma informed gets used way too much. It's way too much of a catchphrase. So we're going to actually break that down in what it means in actual language. And then, of course, I always want to leave you with a tool. and things that you can use with caregivers and kids in this age range. So we're going to do those three, and we're going to be able to hit all three pretty clearly for today for the 2 hours. I'm also going to try to leave questions for y'all at the end, because every time I do this, y'all ask amazing questions. So I want to make sure to leave that. So, but again, and feel free while I'm doing this to Google Kawaka, like NUS, smuggling is. You know the things to Google that won't get you put on a watch list. Okay, so feel free to do that too while we're doing this. So there's some very, very good resources out there for developmental stages. And I'm sure pretty much everyone on this Zoom took a college or graduate course on child development, and none of that helped you. You don't remember any of that. And nor should you, because it was all like Erickson, right? No defense against Erickson, okay? But yeah, do you remember that? Do you remember PJ? I don't, okay? Because I don't use it in my job. I don't need that, okay? So I'm going to give you the thing you actually need to understand child development. Ready? There's some great resources like American Academy of Pediatrics, Healthy Children. Those are relatively easy to find online. But here's the easiest thing out, and you know about children 18 and younger. Ready? There's 3 stages, and we're going to go through the 3 in order. So the first stage, and these are your littles, the age range we're talking about, they're pretty much exclusively in here. Some of your sharper kids might be in the next one, but really this is where you need to focus on. This is what we call egocentric. And the rule for egocentric is A plus B equals me. That is most 4-year-olds and many, many 40-year-old men. But that is not the point of this conversation and topic today. And so, what we mean by A plus B equals me is that anything that happens to a kid in this developmental age range or age span, they are causal. They're the thing that caused it. So the example I use is I had a colleague. I used to live in Oklahoma. I was faculty at the University of Oklahoma Health Sciences Center, and so as Oklahoma City, we have a lot of storms. And this year there was a massive hailstorm this one year. My colleague had a 4-year-old son, and basically, like if the glass is like right there, like the hell is shredding it, he takes his wife and his little son to the kitchen, which is over there on the other side. He's not paying attention, which you don't want to do with a 4-year-old. And so he sees the 4-year-old just run, like he's running towards the windows that are being shattered. He's like, oh my God, my son's going to get shredded. Before he can move, his son stops at the doorway, doesn't actually go into the living room where the glass is falling. He looks up at the sky and his son yells, "Stop it, God." Because he's in an egocentric stage. He's like, I talk to the big guy every night. Like we do our prayers, like got direct main line to the big guy. And so he's thinking like, I tell God I want mom to be okay and dad to be okay and granny to be. Yeah, I can just say, hey, stop it, bud. Just knock it off. And that's a very egocentric thing. And so in this stage, you can never argue them. They cannot be argued or logic out of anything. Their analytic skills, that part of their brain isn't just developed yet. So the thing you got to do in this stage, and most of the therapies we use in this stage are so that the attachment figure can be present and comforting. You see this a lot in disaster response, where um, when we're talking to caregivers who have like toddlers, saying, make sure you hold them, make sure make sure that you're physically there, present and comforting, and that usually helps them out. We'll talk about PCIT in a second. The pride skills, when we get to that part, which is phase 1 of that model, PCIT, that's pretty much what it's centered around because they work within this age range. So they know we have to have it's actually a skill to be present and comforting. I tend to work with a lot with child welfare families, especially parents who are under investigation and are often system kids themselves, like they were born and raised in the system. They don't know how to parent because no one taught them because they're a product of the system. And so we have to, these are learned skills. Some people are much better at this than others, but really anybody can learn it better. And most of the families I work with, especially the parents, they just were never taught it. And so we have to show them the exact skills. Now, maybe some of your like 5-ish-year-old kids and every now and then a 4-year-old will be in this stage, which is concrete. It's A plus B equals C. And the rule for this is anything proximal is causal. And so mom and dad are fighting because of my potty accident, because that's what we were talking about just 5 minutes ago. A test that my mentor would do is I want everyone in their vicinity, like your office or your room, I want you to just look around and glance around it real quickly. Just look around your room. Okay. All right. Did it? Great. If you did not see it, it is not causal in your universe if you're in this stage. So this is why, like, you'll also see really good elementary school teachers nail this. They'll be, Miss, Miss, Miss Sandoval, Haley's laughing at me. And Miss Sandoval, what Miss Sandoval doesn't know is that Michael comes from a domestically violent home, and that morning saw dad beating the crap out of mom. But what he saw proximal at that moment in time is Haley told Kimberly a joke. And so a good teacher will just break this down in a very concrete step by step way. So she'll go, Haley, Kimberly, did you tell a joke? Yeah, Miss Sandoval. What joke was it? We told a joke about a French fry. Would it be okay if Michael heard it? Oh yeah. And you'll see them down regulate the kid by a very concrete step because they just use what's in the proximal environment. If you ever get a chance to watch like a really good third grade teacher, you'll see them do this move consistently. That they really, I say, they never really leave their room when they solve a problem. They can always solve it in the proximal area because they know that this is the stage the kid is in. So you might be able to logic them, but you have to be super concrete, just like that teacher I mentioned. And the easiest way, you just repetition is a big factor for this stage. Just keep telling them, just keep telling them, just keep repeating it, just keep repeating it. Um, and if you're not calm, you can see where a lot of our caregivers fall apart in this, and teachers for sure, then they are not hearing you. So like when we teach private parts, we say the anatomically rather than like my ooh ooh. I don't even know what an ooh ooh is. Okay, I have no idea. Is that even a body part? An ooh ooh, but penis, breast, buttocks, vagina. We want to be very clear about the terminology. A good rule of thumb for this stage: if you're going past 10 words with a kid in this stage, you lost them. You're done. They don't know what you're saying. So make sure. This is why you'll see again good elementary school teachers say, have the kid repeat it. So, um, Cynthia, what did Miss Sandoval just say? Okay, that's okay. So she said that you need to get out your red marker and get out your math worksheet. Okay, good job, Cynthia. Thank you for minding. Right? Yeah, we're not trying to get you in trouble. We just know that you didn't understand a word we said. If this also sounds like ADHD, you're right, because a good rule of thumb is if you're in doubt if a kid is between a stage, you don't know if they're egocentric or concrete, go to the lowest one. Okay, so like if you think a kid is concrete, or just default to egocentric because you're always in good standing there. Where a lot of individuals, especially providers I see get tripped up, is they just go right to this stage. And this is like adolescence essentially in adulthood. It's A plus B equals Y. Now, anybody who interacts with teens or works with them, they kind of suck at this stage. They're really bad because it's like a 15-year-old with a Maserati. Like they have all this horsepower, and most of you are probably aware your brain isn't truly really cooked until like your 20s. So you're going to see some wrecks. So you got to be patient. These are teachable moments, is how we reframe them. If anyone knows the term executive functioning, this is why like they have trouble because they're learning how to drive their car. Their executives are learning how to run the business. They don't know how to do it yet. So work with them, still repeat, but you have a lot more options now. You can, this is why a kid in this stage, egocentric, you have to consequence them immediately or they're really confused. If you wait an hour, like, you know, oh my God, like I don't even know, Laura, why you're so mad at me. It's like you threw a 60-minute tantrum like that. I was like an hour ago, Laura. Like they have no idea why Laura's so pissed off at them, right? Now, kids in this stage, adolescence, I was never more terrified of my mom than when she did the following. I'll go off screen so you can go on screen so you can see me. So when my mom was yelling, we were fine. That was fine. We were all cool. Here's when I get terrified of my mother. When she was yelling, yeah, she's a Mexican mother. That's fine. Okay. But when she did this, Michael Daniel, I'm going to go to my room and think about a consequence for you. I'm like, oh, like I'm dead. I'm dead. That's they're gonna find the body somewhere. I'm dead. I'm just dead. That's all that's going on there. And it's because she's like, I'm an adolescent. I was a horrible adolescent, by the way. We'll get to that later. But she was like, I was like, this is I call it a Michael Corleone. Like she turned into the Godfather. I'm terrified of her now. And you can pull that move into the stage, but you can't pull it in the other ones because adolescents can, even though they say they may not seem like they can abstract out. They can you can wait a little while to consequence it. So we did this with adolescent parents of adolescents is you need to like wait a second. So because a lot of times adolescent parents will punish themselves. All right, so Laura, you're grounded. I don't care. For a week, Laura, I don't care. A month, I don't care. 6. And then later mom's like, I hate this kid. Why I gotta sit with her for 6 months? I hate this kid. Yeah, you just punish yourself, right? So I'll tell Laura's mom, take a second, take a break, you take a timeout, not Laura, and then come back and think of the consequence. That's it. And so and again, that move you can't pull with our younger kids, but it comes online with adolescents. Like, so this is often why you hear parents say, well, I used to tell them something they did the first time. I don't know what's going on. Well, yeah, they were 10. They're now 17, and they're by the way, those of you who have children, I do in full disclosure, I do not have any children to my knowledge, but those of you who have your own children, and they became adolescents, I know that you think they're a different species, but here's what's happening. Pre-teens are puppies, teenagers are cats. That's what happened. You're fine. You still have a kid. You still have a pet. You still have a mammal. They just change species. So like little kids, mom, hey mom, hey mom, hey mom, mijito, mijito, I'm driving. It's like that's your 5-year-old, right? Your 16-year-old. How was school today? Fine. Are you okay? Yeah. Would you like to talk to me? I'm fine. All right, Goda-san, I'm gonna go make lunch. I'm gonna make dinner. 4 seconds later, mom, dude, 4 seconds ago, I told you, I told you not like, and I didn't want to talk 4 seconds ago. Oh no, what? Yeah, that's so they're a cat now, Lori. It's how they didn't lose their mind. They'll be fine. The cat thing wears off in 20 years easily 20 years. They'll be fine in 20 years. And so the common myths I hear for our kids, our little kids, are these are by far the most common ones. Is like they can't do treatment. They're only going to respond to like behavior modification, or the opposite. They'll only respond to behavior therapy. Yeah, Jackie, they'll be fine. Don't worry about it. Like, but by their 40s, they'll be cool. Don't worry. Um, for young kids, like, well, you have to have the most specialized training in the world. A big one is the IQ thing. Well, like their IQ, they're not high enough. Okay, and you can't do CBT because they don't have thoughts. That last one really throws me because whenever I hear a provider or somebody say like, well, you can't do CBT or any evidence-based treatment because kids who are like 3 years old don't have thoughts. I'm like, have you actually talked to a 3-year-old recently? They're all they can't organize their thoughts, but they're all thoughts. Ask any 4 or 5-year-old you meet in the next 24 hours any question. How was school? There was a bug, and I don't know why Tracy had a jacket and the chicken nugget was cold and the puppy liked me. Like, okay, you have schizophrenia. Like, and by the way, every 5-year-old has schizophrenia and bipolar, and they're all psychopaths. Every 5-year-old. That's fine. They mostly grow out of it as they age. Okay. But yeah, Jennifer, that is your grandson. Your grandson is a normal kid. They sound schizophrenic. So when people say young kids have no thoughts, I'm like, I have no idea what kids you're interacting with because all the kids I interact with are only thoughts. Like they're all thoughts and all emotions all the time. So CBT is actually really nice because that's all it focuses on are emotions, behaviors, and thoughts. That's its three big things. So it's actually really well designed for this population, paradoxically. And so a lot of you know this diagnosis, PTSD, and there are resources, and I'll show you some when we get to TFCBT that this diagnosis does fit for our younger kids, like our 3, 4, 5-year-olds especially. But for our 0 to 5 kids, there's a diagnosis that, as psychologists, we're still kind of upset didn't get into the DSM in the last iteration. We're still really sore about it, and it's this diagnosis, developmental trauma disorder. And so this is yes, Laura, your teenage daughter wants a cat because they are a cat. They need another cat around, Laura. And so developmental trauma disorder was created for the 0 to 5 age range. And it was, as you can tell, for PTSD, you need an anchor trauma. And yes, Renee, you'll get access to that. Caltrain will send that out to y'all, and and we'll make another announcement at the end about the PowerPoint. So you definitely can have access to it. So you need a criterion A for PTSD, right? Like something has to happen and you have to remember it, which maybe the kids I work with, like they may have been adopted at 12 months, but that first 12 months they were super neglected. So that doesn't fit a PTSD diagnosis that we didn't think that fits PTSD. We in the trauma world. DSM disagrees with us, we disagree with them. And so I'll just leave it there. The proposed diagnosis with this one was because this one would cover that kid who was neglected 0 to 12 months or 0 to 24 months or 0 to 36 months. And it also looks at chronic events and emotional abuse and also separation from an attachment figure. This is why the massive crisis we're having at the border, at many borders, honestly, of parental separation and parental incarceration. These kids, they may not meet criteria under PTSD, but they 100% meet criteria under this one. The easiest way to kind of think of it, because you can see some overlap between these two, is the keyword in post-traumatic stress disorder is trauma. The keyword in developmental trauma disorder is developmental. These are kids that look like they have a developmental disorder. So if any of you are familiar with a lot of the literature that says like trauma rewires your brain, this is what we're talking about. Is that it's if you think of trauma like a toxin exposure, like smoke. So by the way, smokers on the call, I'm not picking on you. I am a former smoker. And God, I still miss it. Every day I miss it. But that's so like I smoked in my 20s and my lungs were junk. They were trash. But I haven't smoked in about 20 years. By the way, I know I look like I'm in my 20s, but I'm not. Evil doesn't age. That's the reason for that. But I haven't smoked in 20 years. And so my lungs now look like a non smoker. And so, and the reason is that the smoke, I literally rewired my lungs when I was smoking. By stopping smoking, I rewired them in a different direction. So that doesn't sound weird when you think about it that way, but that's how trauma is like smoke. And so it rewires the brain. And early exposure, we have a lot of data that it rewires it. And so we treat it like a developmental disorder. The blue ones you see highlighted here are the ones that are different from standard PTSD diagnostics, like dissociation. I do a lot of work with kids who have sexual behavior problems. Um, and we'll actually get to that a little bit in a second. That's a whole other topic. But and our kids who like, especially think of your adolescents, relationships. Some of my teens who have this do what I do in romantic relationships is they take those red flags down, paint them green, hoist them right back up. Uh, that's what they do. And I am empathetic. I do the same thing. I'm like, yeah, every girl has like 4 or 5 burner phones, right? That's normal for a single woman. No, Michael, no, it's not. It's not normal at all. I mean, that's a bad thing. And so I have those kids right there, like, yeah, they're supposed to be mean and deal drugs. Like, no, sweetheart, that's like, no, sweet, that's not what we're doing. And so we see a lot of these relationship problems too, which is actually isn't present in PTSD. Now, the term will come up trauma informed care. So we're going to knock this out in one slide. Ready? Here, so this term gets used so much that it's now kind of a catchphrase that's kind of lost its meaning. So we're going to make it have meaning. Ready? Here's what trauma informed care means. It means you stop asking one question, you start asking 2 questions. Here's what I mean by that. Here's the one question you never ask again in your career. What is wrong with you? Jackie, what is wrong with you? Amy, what is wrong with you, young lady? No, we're going to stop asking that. Here's the question we're going to ask now from now on. 2 questions. Susan, what happened to you? What have you been through, kid? And the second question, Dolores, what were you supposed to get that you did not? Most kids are supposed to get a dad who's not a violent alcoholic. It didn't roll out that way for you. You deserve to have a dad who didn't do that. That's a omission and commission is a way to think of it. Okay? The very quickly, I'll tell you this one. The most dramatic example I have of that, I'm off screen intentionally. I'll go back on in a second. Is I had a teacher and a principal. One of our kids, he had been kicked out of every school in Oklahoma County, and he's a fighter. I don't slide him for that, but definitely the schools did. And basically, the VP was holding the line. The principal wanted him out. And the short version is we were having a giant all stack because it was a year after the kid got found in a garbage can, literally. And the VP's son broke his arm. So the principal, the guy who wanted the kid out of his school, but the VP was holding the line, he had to sub in. And I had about, from our lobby to our conference room, about 60 seconds to prep him. And so we're doing an all staffing, we're going over the whole case. The guy found out why the kid wears sweaters in the middle of summer in Oklahoma because mom never hit the face. She was smart about that. So we're about 30 minutes in. He's sitting right next to me. I can't really talk to him because it's a full staffing, but he is white as a sheet by this point in the meeting. We got another hour to go. And I look at this man, and again, he's seen the whole history of this boy, what has happened to him. That's what he's seen, that first principle. And the second, by the way. And I look at him and I say, Mr. Smith, are you okay? And barely above a whisper, here's what this guy says. And he's just looking down, like just white as a sheet. He says this, I'll do whatever you want. The only reason I let the man go back to his school was because it was 2 miles away. So I called the secretary because I worked with the school a lot. So I talked to her a lot. She's like, what did you do to our principal? I'm like, no. Short version is that man is the most dramatic shift from what is wrong with you, young man, to what happened to you and what were you supposed to get that you didn't. Because after that, if a teacher came up to him about this kid, Mr. Smith, I think Johnny is being a little aggressive. Here's what he would do. Okay, you know what? You're going to work it out. You're gonna work it out. You have no idea what this young man has been through. He would kind of get in their face about it. And later down the road, and all due respect to this man, later down the road, I said, "Hey, man, I'm sorry, I didn't mean to ambush you like that." He was still processing it like 6 months later. And I remember what he said. He goes, "Dr. Gomez, I didn't know this world existed." I'm like, I know you didn't. I said, it's not your fault. Monsters exist. Monsters do horrible things to children. And he was still processing. It was a world he had no idea. If anyone knows the Bruce Perry book, It Happened to You, Oprah Winfrey published it with him, and Oprah Winfrey is a national treasure, and that's just going to be one of our kind of like general principles of the world for this talk. She's a national treasure. Okay. That's what he's referencing is trauma-informed care. What happened to you? That's why it's titled that way. Another good resource on the site is Cassie Cassell's. She's out at Northwestern. It's called rememberingtrauma.org. And it's one of our resources. It's for kind of older kids, but it looks at race and trauma, culture and trauma, historical trauma. It focuses really hard on that. And it's a video, a short film about a transition age youth. But in the second video, it's the same video with expert commentary. And I think it's Dr. Cassell. She has a phrase that I use all the time. She says, traumatic stress is the great imitator, meaning trauma is supposed to look like everything but trauma. It's supposed to look like ADHD, depression, anxiety, bipolar, autism, headaches, weight gain, learning disabilities. Autism is supposed to look like everything but what it is. Holler to Sylvia, the Bruce Perry fan. Holla. And so it's an imitator. It's a spy. It's supposed to get in to a system, and and once it's in there, it's pretty stuck in there. That's all. I use that phrase a lot with educators, especially childcare educators, because again, I know I look like I'm in my 20s, and so I'll get an educator. Dr. Gomez, I've been teaching children for about 30 years. I think I know a thing or two about children, Dr. Gomez. And what I want to say to this woman, and I never do, and I'm very proud of myself, folks, is you do something wrong for 30 years. I cooked eggs wrong for 5 years, and then I had a girlfriend show me sunny side up. Now I do it right. Do something wrong for a long time. But I do not say that. I don't say that. Okay. What I say is, Miss Smith, you're right. Trauma is a great imitator. Its only job is to get by a 30-year educator. That's its only job. It's really good at it. And I was at a conference, I think it was Pittsburgh, and coincidentally, one of my colleagues who does pediatric HIV research was there. We were not at the same conference, we just ran into each other. So later that night, we're having dinner, and I say this phrase, we're on the topic of what we're doing for work. Trauma's a great imitator. And he says, I think that's a lot like HIV. And I'm like, I'm not familiar with the HIV lit. And he said, HIV is photosensitive. I'm like, I don't know. He said, okay, take the human immunodeficiency virus, put it on a petri dish, expose it to light and air. It dies relatively quickly. It's why sweat doesn't transfer it, spit doesn't transfer. It's gotta be fluid to fluid. Once it's in you, it's kind of it barbs in there. But if you expose it to light and air, it dies relatively quickly. And I'm like, actually, that is like trauma. That's a pretty good analogy. So traumatic stress is a great imitator. So if you have people that are tied to a diet, especially school-based providers or education or childcare, he has RAD. That's all he has. He's just reactive. We don't have to debate them, say, well, it's an imitator. That's what trauma is. It's supposed to look like everything but trauma. That's its job. That's how it survives. It's the only way it can survive. We're going to be honest about it. So trauma-informed care. Don't ask one question, ask two now. And that's what we need everybody else in the system to do. And you're gonna be the champion of that, by the way. I apologize for making you that person, but sorry, not sorry, because y'all will do a great job at it. And that great imitator is a phrase I use a lot. Now, this is for all child trauma. It's and so, oh, thank you, Sylvia, appreciate that. um this is not just for young kids, this is for adults. What we want to make sure is that first there's some type of tracking of symptoms, whether that's headaches, because the kid's tummy aches for our little itty bitties, regressive behaviors. We want to kind of get a baseline of what's happening, but then we also want to educate not just the kid, but the caregiver. In a second, I'll show you some really great resources for that. Like, so one off the top of my head is we use a lot of storybooks. So there's one called Please Tell. It's also titled Jessie's Story. It's a little girl named Jessie talks about her sexual trauma. It has her language, her drawings, and she talks about how she got better. So we have maybe days for kids who are in foster care. And so there's a lot. So we do that with the kid and with the caregiver. A lot of my caregivers, not they do have their own trauma. Their child was sexually abused. That's a trauma for the caregiver. but a lot of them I'm dealing with intergenerational trauma. I'm dealing with parents whose whose entire family, every female member of the family was sexually abused going back to the Civil War. That's the families I'm dealing with. So we got to show them that this is how trauma has affected. If anyone knows epigenetics research, they do this on steroids. It's awesome research if you're interested in it. But like, yeah, this isn't. You'll hear me say it's not you, it's your trauma. Your trauma's dragging the bus. Um, and one thing I did a year in combat stress at the Veterans Administration, so I did adult trauma work. The guy taught me most of what I know about adult trauma. A guy named Victor Wong. Um, One day we're having lunch and he says, "You want to know the summary of the last 50 years of PTSD research, Michael?" Like, yeah, Vic, yeah. What is it, man? It sounds awesome. Here's what it is. It took us 50 years to realize it doesn't take 50 years to get over this stuff. That's what all we learned in 50 years. Well put, my friend. Well put. Okay. So I'll tell parents, especially intergenerational, mom, Miss Cunningham, I realize I'm asking you to draw a line in the sand against a century and a half of trauma. I get that. I get how I'm saying that, but I wouldn't be asking Miss Cunningham if I didn't know you could do it. That's why we're here. Yeah, yes, Gabrielle. Historical intergenerational. That's that we put that in part of the education. We have Aisha Metzger coming up at some point in the series for y'all. I love Aisha. She's great. I agree with Aisha. You'll hear her say in a lot of her talks, if you're not doing work on racism and inequity in the trauma world, you're not doing trauma work. It's so deeply embedded in the experience of trauma, you can't get away with it, and you shouldn't. I mean, it's part of the trauma. And so her when you hear her talk, she's gonna blow you away. And you can access her stuff like right now. I think it's draishametzger.com is her website. And so we integrate a lot of that into the models we use across the age span, including this age span. But historical intergenerational trauma, that's right. So Aisha Metzger. Oh, they beat me to it. Um, and so and we don't want to just educate them. We want to give them some skills. Like if the kid's not sleeping, we want to give them some skills to help with that. If the kid's having anxiety, we want to give them skills with that. The direct, the these direct inspiration and exploring the attributions. We want only a professional to do that. You don't have to do that. The other ones you can do the assessment, psych ed, stress management, inclusion of caregivers. You can all do that today. By the way, I call the direct exploration of the trauma psychological surgery. It's the safest surgery, but it's also as delicate as surgery. And there, TFCBT will talk about has a very particular protocol for that. That's very safe. Okay? But if you want to ask one question, if and want to figure out if a caregiver is actually getting effective child therapy, just ask this one question: Mom, what is the therapist doing with you? Not like, do you have, please get their own therapist, but that's not the question. The question is, what are they doing? How are they including you, mom? And if you hear crickets, then they're probably not doing anything effective. That's what most of our data shows is that there was a research study done at Harvard by a guy named John Weiss who asked very simple questions that are very difficult to answer. And one question Dr. Weiss asked was, what makes therapy work? Not just trauma therapy, but therapy. And this man looked at everything. Is it master's or doctorate? Is it inpatient or outpatient? Is it school-based or home-based? Is it twice a week or once a week? Is it? And he found that the strongest single predictor of if a kid gets better in therapy for ADHD, DMDD, depression, bipolar, autism, PTSD, OCD, pediatric obesity, medication compliance, pain management, and a bunch of other things is caregivers. That's it. Probably didn't need a PhD to tell you that, did you? Okay. 168 hours in the week. I would see your kid one or two. It is arrogant and disrespectful to think I can fix your kid in an hour or two. That's a pretty arrogant thing for me to say. What is more intelligent, more tactical is I put my knowledge in your brain, mom, and you have a trauma therapist forever. Right. So you'll hear me say a lot, caregivers are not the problem, they're the solution. They may approach you like a problem. They may get in your face like, but they're really the solution, right? And that like we can't do we can't like you are my MVP, mom. And if LeBron doesn't play well, we don't go to finals now, do we? Because I lost money on that game, and I'm still upset about that. All due respect to LeBron, but still, like if he's not playing, we do not get to finals. Okay. Uh, as you can see, I'm still a little sore about that last season for the NBA. And so yeah, you're my MVP. I need you here. I need you healthy. And so that's why you can't just drop your kid off and I see them. Okay, because you're the solution. You're it. Your only hope, Obi-Wan Kenobi. Okay. And so we also want a specific time range. So when I first started doing child therapy, to go off screen intentionally, Yeah, I was doing school-based, home-based, office-based, therapeutic classroom, kids who were SED, young kids. And here's what I would get a question. Mr. Michael, how long is this how's drama therapy stuff going to take from a boy? Uh, well, Ms. Perez, we have to figure out a couple of things kind of like ecological factors, attachment bonding, we have to, take a look at psychopathology, cultural factors. It's also summer solstice and Sagittarius is in orbit. Now, I BS my way. I don't know therapy ends. No one told me therapy ends. I didn't know that happened. Like, they just thought you see therapists forever. I have no one told me how therapy works, right? They're just like, I had no idea. That was me in grad school. Here's me today. Ready? Dr. Michael, you said my kid has something called developmental trauma disorder. You just be straight with me. How long is it going to take for to see my kid get better? Um, Diana, what we're first going to do is we're going to figure out what it looks like because it is possible. It's something we call PTSD, which you may have heard of, but it's looking like the second one, developmental trauma. The difference is this is strep throat. This is antibiotic resistant strep throat. It's a nastier strain, but we can treat it. This one for a kid that's about 4 years old takes about 12 sessions, start to finish. Doesn't mean we're done with the whole therapy. As Cynthia says, it's a process. Doesn't mean we're done with the whole thing, but we're done with the trauma part. We get the bleeding to stop and resolve. This one, we double it. May take, over 20 for this age range. For our teenagers, it may take 50. But either iteration your kid has, Diana, you should see improvement in about, 4 to 8 weeks, 4 to 8 sessions, provided you're doing everything we're talking through. Totally different answer. And I just didn't feel ethical not being able to answer that, right? Imagine if you went to a pediatrician, uh, Dr. Gomez, how long is this antibiotic going to take to work? Well, I don't know, there's things you got to figure out, it's kind of complicated. You would be calling the medical board. Like, no, this is my kid. I need to know, like, this shouldn't be a difficult question. And so the reason I put a hard emphasis on evidence-based treatments is because they're able to answer that question much more clearly than when I was doing that weren't evidence-based. And so I just thought I owe that to my parents and my kids. I mean, that's the minimum I owe them, right? So let's actually go into the actual treatments. I'm gonna give you, these are not the only ones. These are just three really, really, really good examples of what they look like. And again, these all hinge on the following principle. Caregivers are the solution, not the problem. So the first one is PCIT. And here you also see their website where you can find a certified PCIT therapist, information on like, if you're a therapist, how to get certified. This is a very busy slide and I apologize, but I'm gonna break it down real quick. So the first part, there are 2 phases. It's about 15-ish sessions, give or take. This is not session based. This is skills based. So the shortest I've ever done PCI, because I'm a PCIT therapist, the shortest I've ever done it is 8 sessions, start to finish. They flew through. The longest was 32 sessions, and here's why. In phase one, Dad, I this also, as you can see, the highlighted on red, this is one of the few models. There are now, I think, 12 studies, by the way. This is one of the models that if you have a parent who is physically abusive or neglectful, not sexually abusive, it's very important. That's a pedophilia treatment. We don't do that, at least at our center, that they work. Like they don't reoffend again. The studies were done originally in Oklahoma. They've been replicated at Arkansas and UC Davis over in the West Coast. And the reason we think this works for those kind of caregivers, which make up the lion's share, the super majority of anybody coming into child welfare investigation, is the to give you kind of an actual example of how this model of why we think this model works for offending caregivers, is we don't change the child, we change the reactivity of the caregiver. That's central to it. Um, and but here's the reason why, because I was part of the original studies of this, and I went off screen intentionally. And here's what. So I was in CASA. This matters for this particular section. Court appointed special advocate. And when I was doing CASA work, I would go to court and I would see a adult man, and then I'd see a 5-year-old with a broken nose, and the guy would say, "We're just disciplining my boy, Your Honor. That's all." And my thought was, "You're a freaking liar. You're just trying to get out of jail time. You are a piece of crap liar." And some of them were, but I did the job long enough where the radically more disturbing conclusion reached my brain, which is, oh my God, you actually believe that. You're not BSing me. You think punching your 5-year-old in the mouth is discipline. Because your dad did that to you, your grandpa did that to him. Like, yeah, that's actually a thing you believe. And so We went and we here's where we started in Oklahoma. Maybe these aren't evil people. Maybe they have no idea how to parent. If they are evil people, we will find out if we teach them how to parent. Like it's a win-win. Like there's no way we lose in this scenario. And so maybe that's why they just don't know how to do this stuff, right? And so I remember one mom who was in the trial. She had 4 child welfare investigations, 2 removals, and she was on her 5th one and got deferred from court to us. And it was clean UAs, get housing, get a job, go to PCIT. That was her requirements from the court because it was a state initiative we were doing in Oklahoma. I was her therapist. Session 2, we're trying to practice labeled praise, like saying nice things to her son. She is not doing well at all. She is struggling. So I pause the session. My co-therapist goes in with the kid. I pull mom into the observation deck because we have that kind of law and order mirror set up. And I say, Mom, what's going through your head? And background of mom, she grew up in the foster care system. She got in foster care at 5, was the system beat her down. She aged out. She's now like 25, drug problem. She's like barely holding on to sobriety. Like, she's had a tough life in the last 20 years. And I say, Mom, what's going on? And here's what she says: I can't freaking do it. And I'm like, the praise? Like, yeah, like, why do you, like, I never got it. Okay, so Mom, I believe you. I'm not, Miss Smith, I'm not saying I don't believe you. I 100% believe you, but I want to make sure I understand what you're saying. You're saying, and I do believe you're truthful in this. In 18 years of childhood, no adult ever gave you a praise. Is that what you're saying? Yes. That may be the saddest thing I've ever heard, Miss Smith. Would you like to give that gift to your son? So I'm in here. I was like, I can work with that, right? It's like, yeah, I did. And she did amazing, right? But we started off with maybe in 18 years of childhood, no one ever praised you. No one ever supported you. You were beaten down by humans. That's essentially what it is. And to kind of double back for a second, the big difference between standard PTSD and what we call you also hear developmental trauma called complex trauma, complex PTSD. They're used kind of interchangeably. Here's the difference. For PTSD, the trigger is usually a sight, a sound, a smell. Like there's usually you can usually kind of reach the trigger. Like, oh, um, Cynthia freaked out. She was in fireworks, 4th of July. She was in Iraq. She's a veteran, right? I can kind of piece it together for Cynthia a little later, but the developmental trauma people, here's how they work. This is what triggers them. Ready? Hi, Ladidra, how are you doing? Like, then like pupils dilate, sympathetic nervous system response, cortisol goes up, adrenaline, like Ladidra's ready. And that's because the trigger for someone with complex or developmental trauma is not a sight, not a sound, it's a human. There's actually only one trigger for those people, humans. Humans are the most dangerous entity on the planet Earth to someone with complex or developmental trauma. And the first kid I ever had with trauma that I ever worked with, some of you may be familiar with the ACEs study. His ACE score was 9 at 16. That was his ACE score, 9. And I don't know why this kid liked me, but at one point, I've been working with him for a year. I was obviously a mentor. I don't know if I really mentored him though. Like, but he says, apropos of nothing, we're like eating pizza. He goes, "Hey man, I like dogs better than people. Can I tell you why?" Yeah, why? Here's why. Dogs can do some terrible, horrible things, but first, they never do it without a reason, and second, they never like doing it. That's why I like dogs better than people. Really good reason, right? Yeah. So the trigger for people with complex or developmental trauma are humans. Laura's right. We're very difficult, dangerous species, right? And so that's why I'm not anti-pet, anti-equine therapy. I'm definitely not anti, but I think they make a mistake because often they see it as a like you go to equine therapy, you're done, you're cured. And that's a huge mistake because here's what's going on. Is a horse a human? No, a horse is a horse, of course. That's why they're not triggered. Okay. And so I'll start you with a horse or a dog, or I don't care, hamster, doesn't matter. But I need you to move on to some human. There's a lot of them around, and you don't have to have all relationships, but just have some healthy ones. Like we need to give you, like, find your connections, right? That's what we need. And so in PCIT, we get those parents and we work with them on that with like, yeah, you probably have the trigger as humans. So us punishing you isn't going to work. One of the judges I work with in Colorado, his name's Robert Lung. He says you can't punish someone with hell who's already there. Like, like, what are you gonna do to this mom, right? Yes, thank you, Rosemary. It's a great show, though. Nick at Night was I grew up on. But yeah, you can't punish someone who's been through hell, who's already there, right? Like that mom who was beaten by the system for 20 straight years. What are you gonna do? You're gonna yell at her? That gonna make her listen? No, that's been that's her Monday night, right? You ain't got nothing. Instead, let's try to assume you don't know how to do it. Would you like to give these gifts? You'll hear me say that. Would you like to give this gift to your son, to your daughter? and she did great with that. And so, and the things we do it in two phases. We can't switch the phases. So phase one is the attachment phase. We build a relationship. We'll show you that slide in the next one. The second phase is what we call the discipline slide, the discipline phase. And we were asked to switch them in a study, and we had to shut the study down because here's what, if you do the discipline stuff first and don't do the attachment stuff first, here's what it looks like. Veronica, sit in that chair. If you don't sit in that chair, like, oh God, that looks gross. That looks coercive and abusive, right? Yeah. And that's like kids without abuse. That's what it looks like. There were no abuse kids in that study. And so we was like, let's look at the relationship. Let's look at the attachment. Let's rewire it. There's also, just so you know, that this multiple studies showing that this works also with kids with autism, kids who are not neurotypical. It's really nice. This is what that first phase looks like. We make it very concrete and very doable because the word attachment is a very big word. And so we just make it addressable. We make it very comprehensible. So we talk about do skills and don't skills. Exactly, Patricia. Connect before you correct. Love it. Perfect. Yeah, you're gonna love this model. And so the don't skills are no commands, questions, or negative comments. So, Andrea, are you saying I can never ask my kid a question? No, for 23 hours, 55 minutes of the day, you can ask as many questions you want. It's only that 5 minutes every night you're playing with Legos and colors. We want you to practice the do's. We call them pride skills. Okay. Um, by the way, we code this, like we look at this like in vivo. And here's the reason why we actually could track this in an actual session is because um, there again to cite John Weiss again over at Harvard. He asked another simple question: what makes parenting programs work? And here's why. Especially those of you who work with child welfare. Miss Keith, I went to the 12 weeks over at the center. Give me my kid back. And Rosemary, as a child welfare worker, has to give me my kid back because I checked the box. But then 6 months later, I neglect my kid again, and I'm back in child welfare investigation, right? I work with those parents who they should get a punch card because at least on the 12th investigation from child welfare, they get a free snow cone. They get something, right? I mean, you gotta get. I mean, you're on investigation number 10, right? And so, like, yeah. And so, what John Weiss figured out is there's one thing. There's really one thing that separates parenting programs that work from those that don't work. Technically, it's not evidence based. Here's what it is: direct practice. So PCIT does coaching. We have like a law and order room, or we can do it. I've done it over tele. There's IPCIT that exists. I've done it a lot. They have a bug in their ear. We're observing them over the screen or through the glass, and we're coaching them on what to do, right? And that's where it's direct practice because how fast can a caregiver mess up a praise, right? Um, Thanks, Patricia, for taking out the trash. I don't know why, Patricia, uh, that's how fast they mess it up, right? We had a grandma in our foster care group. Grandparents raising grandchildren are the largest demographic of foster parents in the North America. 4 weeks it took this woman to learn labeled praise, but she got it. Week 4, she comes in group. Dr. Schmidt, Dr. Gomez, figured it out. What'd you figure out, man? Praise and shut up. Yeah, actually, yes, for a month. That's all I've been trying to tell you. But you got it. And so we have to do it in real time, right? We can't just like teach them and then send them home. So PCIT does direct coaching with like bug in the ear. PMT Organ Model does role plays. I think Love and Logic does role plays. Incredible Years does video scenarios. So whatever you're using for behavioral stuff, just make sure you see them practice it in vivo. So I'll give you an adolescent example because it's my favorite one. So um, I want to, oh yeah, exactly. There's a need behind every behavior. Exactly. So Gabriella, let's say your daughter comes in and is taking out the trash. What could you say? I don't know why that was so hard. Okay, Gabriella, that's a great take one. Let's go to take two. Okay, Gabriella, take 14. Like, Sylvia, thank you for taking out the trash, Mihita. I appreciate you when you help out. Okay, we're gonna do one more take just to clear. Ready, Gabriella? I come in, I'm Sylvia, I take out the trash. Go, okay, action. Thank you, Mihita, for taking out the trash. I appreciate when you help out. Whatever, mom. What are you gonna do, Gabriella? What you gonna do now? I make sure to do it. That's our whole session, by the way. That's it. And this is what these PCIT sessions look like. Is they look like us just practicing a skill, making sure they're getting it down, and that they can translate it at home. So we call it pride. We want labeled praise. And some people ask us why is labeled so important. Hey, Patricia, great job. Okay, ready? Hey, Patricia, Great job with the comment you just made. That was a very insightful comment you put in the chat box. Now Patricia knows exactly what she did well. Okay. And actually for that, how to do the laundry, we have to break that down. That's another thing. It's like when they give a command, which is the second phase, we want them to do micro commands at a time. So I'm assuming Dolores not asking about like a 5-year-old. If 5-year-old can do the laundry, that'd be amazing. I grew up in a Mexican family, so we were expected to like drive the car, wash everything. Like that was our expectation. But I do not consider that universal. Okay. And so we want to lead with this. So praise, reflecting. We found a beneficial side effect that PCIT helps kids with language disorders. I got the ball. You have the ball. Oh, I thought you like that. So we're reflecting the language. We want them to think, I appreciate your validation, Laura. We want to imitate behavior, describe behavior, not in a judgmental way, right? Like, why are you doing that, Veronica? It's like you have the bolt, you have the box, and you're putting it on the table, and now you got the crayon. And the last one used to be called the drip skills. The reason we have enthusiasm is because we worked with parents with postpartum depression. They had like 3-year-olds and they were postpartum depressed. And so we like, hey, just fake it till you make it. And so this is our, like, we do this until they can meet 10 praises, 10 reflections, 10 descriptions, and no more than 2 commands, questions, or negative comments in a 5-minute coding. That may sound easy, it's really, really hard. The only discipline skill we give them in this phase is active ignoring. And even that can be hard for them. And here's why. One of my favorite parents, ready? Like, I'm ignoring you, Laura. I am ignoring you. No, you're not. And the reason that is not a great ignoring technique is the relationship between attention and behavior is the same as between oxygen and fire. Now, to Glee's question in the question and answer, how should we respond to children with emotions? That we're actually going to get into that in the next thing in CPP and in TFCBT. But like if you're doing PCIT, what we'd often say is, well, reflect the emotion. Like, like it's okay, validate the emotion, I would say it. It's okay to have heavy feelings, Jackie. It's okay. It's to be more soothing, warm. Like especially the parents I have who are lifers or like they've been beaten up by the foster care system. I say, anytime you think you need to attack, soothe, comfort. Again, remember the set stage you're in. It's comforting and soothing that are most effective at this developmental stage, like 0 to 5. So anytime you need that, because they're triggered, they're like, yeah, I gotta attack because like I gotta be tough because I'm a foster kid, right? I'm a 28-year-old foster kid, right? And so we want to make sure that we anytime you think you need to do that, we're going to go to soothing and comforting. And that's why they need help with that. That's not a natural organic muscle that they have. If they had it, they wouldn't be seeing us, right? By definition. They're there to learn. And so we should be there to help. It's a great question. And so now this is a busy slide, and we're not going to go through this whole thing, but this is what PDI looks like, the phase 2. We start with commands, and this is what a timeout sequence looks like. This is only half of it. This is the whole sequence, by the way. Like it looks like a jet engine schematic. But you can see even within the commands, we call it be direct. We want this is kind of goes to the laundry question. Be specific. Like stop messing up the laundry. Take out the clothes. Developmentally appropriate. Like for like a 4-year-old that might not like put your socks in the hamper would be probably good for like a 5-year-old, but maybe like doing the whole laundry. But breaking it down in individual versus compound. Um, and timed explanations. Here's what we mean by that. Put up your shoes, Jackie. Why? If you put your shoes, go to time out. Fine. Thank you for reminding Jackie. The reason we need to put up our shoes is because grandma's coming. Or a good alternative, grandma's coming over in about an hour, Jackie. So we're gonna start cleaning up. Please put up your shoes. Why? Already told you. Don't need like I already gave you the answer. Um, the next thing on that PDI, that the only thing, and then we'll move to the next model. We're going to talk about CPP. Again, all of these have very intricate training regimens and a training structure that if you want to, you can go to their websites and get information on that. But very important for traumatized kids across the age span, not just 0 to 5. This is a story so sad, it is true. My blessed saint of a mother had the misfortune to have the two types of children in the world. Okay, there's only 2 types of children, and so oh, and actually, Kimberly, for phase 2, they have completely changed it. Now they now have created. Thank you, Robin Gurwitch over at Duke. Instead of doing CDI PDI, they do CDI TDI, trauma directed interaction, and then they go to PDI. So they honestly, they just take out the timeout room. That's a big change. So that is brand spanking new. They just this year rolled out TDI training. So Kim, if you are a PCIT or Kim, you can contact Duke, Robin Gerwich directly. And they're looking for people who are interested in this because I'm a trauma person and we have that same complaint. Like, what about the traumatized kids who are locked in a closet? We can't do a timeout with them. And so they answered that. They took about 5 years to answer it. Thank God for that. Okay. But yes, good. So there is so that's why I talk about PCIT and not other behavioral models, because other behavioral models are very behavioral. This TCIT has a very hardcore trauma informed lens wired into it, even more so now since the TDI, the trauma directed interaction. So now CDI, TDI, PDI. Yeah. Thank you, Robin Gerwich at Duke. And so the two types of children in the world, my brother was the first one. When he would get in trouble as a young man, my mom would say, Mark Anthony, you're in a great deal of trouble, young man. And my brother would go, I'm gonna punish myself, mom. I'm sorry. Because he's a stick kid. He's a vinegar kid. Like you just and that's not a bad type of kid. That's how most of the society works. I'm pretty sure Laura has never been driving like down the highway, get pulled over by a sheriff's deputy. Let me see your license registration, ma'am. Um, okay. Thank you, Miss Santana, for driving the speed limit. You have a wonderful day. Laura doesn't do that because the only reason she doesn't speed is because her friend texts her, hey, there's a speed trap. I know you like drive like a freaking demon everywhere. So slow down when you get there. That's it. It's the only reason Laura doesn't speed. And so, yeah, and that's most of the world. I, however, am the other type of child. Okay. So when my mom, my blessed saint mother, would get in trouble when I was young, she'd go, Michael Daniel, you're in a great deal of trouble, young man. And my reaction at 8 years old would be, oh, yeah, Racy Rich, I did, mom. You got to be living, man. That was me at 8. And the fact that my mother didn't murder me makes her a saint. Okay. By the way, if you have that type of child, I still apologize to my mother. Okay. Like, I'll call her and like, mom, I'm so sorry. It's like, Mijito, what happened? 1998. I was like, the records are sealed, but I'm very sorry. And sorry. And so here's the important thing. There's a study that I use to show why scientists like me are sociopaths. Okay. And the short version is in the book Behave by Robert Sapolsky. And here's the study. He makes it very simple. I'm going to make a lot of neurology very. If anyone has a neurology background as there's discipline, I apologize in advance. I'm going to butcher your discipline right now. So there was a rat study, and they had two conditions. The control condition was the following: mama rat has baby rats. When the baby rats are mobile, they put them on this apparatus. Baby rats go here, mama's rats here, and they have a bridge. So when the baby rats are hungry, they feed on mama rat, then they come back, they reset them. The experimental condition is the exact same thing, except there's one difference. That bridge is electrified. Not all the time. We don't know. Maybe it's never, they don't get a shock. Maybe they get a shock the whole time they're crossing. Maybe they get a shock for 30 seconds. Don't know. That's not the sociopathic part. Here it is. They vivisect all the rats and they die. They kill them and vivisect them. Okay. Sociopaths. Okay. That's scientists. Okay. And so what the short version is this: most mammals' brains work this way. Bad things, pain, good things, pleasure. The rats in the control condition, their brains wire that way. The rats in the experimental condition with the electrified bridge, their brains did that. And so I am, as a person, very upfront with my own history of lived experience of childhood trauma. And in high school, the only reason I got to college is my high school English teacher, my mother, and a high school English teacher. Through a clerical error, I got an IB English in high school, and I did not like it because it was 28 white kids, me and Charisse. Okay. And so I was not comfortable. I spent most of my time in school suspension because it's 8 hours of no one bothering me. I can blow through my work in 3, and I just read the rest of the time and drink coffee. I am, as an adult, trying to get back to in school suspension. If anyone can help me with that, I got kicked out of straight. It was the best deal I had, right? I just go to ISS and like, yeah, just chill out. No one bothers me, right? Love it. I just read the whole time. Loved it. And so I was trying to get back there. And so I'm doing something behaviorists will know as an extinction burst. First week there, I'm orienting. Second week, I'm cutting up. Third week, and then it was the middle of September. I drop an F bomb in her class. And so Miss Duncan is ignoring. She's doing all these principles beautifully. My English teacher's name is Duncan. And I'm trying to get back to ISS, right? And so um, the way she had her class set up is every month you have a group leader, and 80% of your grade is on your group leadership for that month. She's trying to teach leadership early. She's an amazing teacher. And so when they assign them like December, give me this. I want to get out of this class. I don't give up. Just give me December. And so I drop the F bomb. The class is ends it right before lunch starts. And she says, Michael, I need to speak to you before you go to lunch. So I'm like, great. Go up. She doesn't shame me. Waits till everyone's out, and then I go, "Yo, Misty, what's up? What you got?" And she goes, "Well, Michael, I wanted to just update you on something." So uh, I talked to Diana, and I know she was going to be group leader for October, but I talked with her, and she's going to switch with you, and so you'll be group leader in October. And if the group passes, that's because of you, and if they fail, that will be because of you too. I'm like, no, 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 you can't do that. You got to remember when I cussed earlier. Here's what this woman does. She goes, "Oh yeah, I think I remember that." Like, it's like, yeah, you gotta kick me out. You gotta send me to ISS. And here's what she says. She goes, "Well, I'm not a fan of that, obviously, Michael, but I think you're very intelligent and show great leadership potential. So I'll see you tomorrow." Freaking woman, do what every other teacher I've ever met does and not give a crap. I factor that into the equation. Leave me alone. Why are you doing that? Like, she's probably the reason I went to college, honestly. She gave me my college application, honestly. That like she just kept why like I don't know why she took an interest in me. But here's the reason I'm telling that story. For every other kid, yes, I do too, Jenny. She's a wonderful woman. Every kid, ISS, bad, pain. English, IB English, good, pleasure. Mine had switched because I was the rat in the experimental condition. I had a solid decade of shock. And so she caught that. And so when you're if you have a behavioral background, like you do a lot of child education or child intervention with this age range, watch out for that because that's a trip. I work with ABAs all the time and they miss that. They're like, well, that should be reinforcing. Trauma can make it opposite day. Is the short version. Okay, PCIT is really good about changing opposite day back to like regular day. It's not the only game in town, but it provides a really good framework, especially for educators, like providers and parents. It's a very and there's models for adolescents that we have, but we're just going to stick to our age range. And so yeah, right, Ruth. Thank you for yay for great teachers. And so keep that in mind. That's the in that phase two. That's the biggest misstep I see people do is they don't realize that the reinforcer and thing that's rewarding and the thing that's aversive may have flipped because of trauma. They may not get that. It's like you see this a lot with kids with autism. If when I touch them, it hurts them. Yeah, they were neglected for a year and they have autism, and it might, we're gonna have to have an OT work with them. So if anyone does stuff like sensory work, stuff like that, somatic work, more power to you. We need that stuff like in spades for those kids. And all this can be really integrated into these models. So we're gonna go to that just for sake of time. We're gonna go to the next one. Child parent psychotherapy is a great model, and this one covers 0 to 5. I think 0 to 6 actually. And like PCIT, you'll hear them say we're going to speak play, and parents learn how to speak play just like you would learn how to speak Spanish. And the reason you speak play is you're trying to metabolize stress not just for the kid but for the parent, right? So that we'll see a 12-month-old in CPP. We'll see, so we'll see kids who like that are very very young that I think the youngest CVP kid I saw was 6 months old. And to give you an idea of what this actually looks like, I'm gonna actually let one of the actual trainers tell you what it looks like. Okay, so here's what CVP looks like. So let me get it up and running. Oh, there it is. Okay, here we go.
Child Parent Psychotherapy, or CPP for short, is a therapy for children birth through age 5 who have experienced really scary, dangerous, or violent things such as child abuse, so physical abuse or sexual abuse, or car accidents, or even experiencing things like being in a fire or a tornado. CPP is evidence-based, meaning that there is a lot of research behind the effectiveness for using this treatment with young children and families. We know that CPP is effective because of the research that we have. So treatment is conducted on a weekly basis. So children and families are seen by a therapist for weekly sessions. As part of the treatment, children and families are seen together. So one child and one caregiver may be present. CPP really aims to build skills within the family and improve the relationship between the caregiver and the child, and also to help the child heal from that scary, dangerous, or violent experience they might have had. CPP is wonderfully powerful and effective when in the hands of a well-skilled therapist to be able to really help these children and families learn.
In CPP with children, it allows us to speak their language, in the language of play. It helps parents to tune in, become attuned to what's going on in the present moment and what's in the room. It helps us to align with children in their point of need. And it also allows children and parents to continue to grow. It kind of restores and heals and allows children to get back to the business of being kids. One child really sticks out in my mind when it comes to CPP. It is a very young girl who had some really severe panic attacks, had difficulty when parents left the room. Through the process of CPP, she was able to use toys to just kind of convey what was going on the inside. And as she played, and the parents played beside with her, they were able to communicate in ways they weren't able to before.
We find it to be tremendously useful and helpful and healing for children to be able to speak what's been unspeakable before, or show through their play what's been unspeakable before, so that they can begin to heal and move through that traumatic
Thank you,
experience.
Arkansas Medical Center, one of our dear friends in the light. You'll see that also kind of like one of my colleagues who does a lot of CPP on the West Coast points out something fairly obvious in hindsight, but I didn't actually catch it until she pointed it out. And it's, think of most of these parents have their own trauma history. They're coming in just tons of trauma, right? If you have grown up in a traumatizing environment, in a violent, dangerous environment, in an invalidating environment, did you get a lot of time to play? No, you didn't. You got a lot of time to survive. Like surviving is not playing, right? By definition, like one of the family I work with in PCIT, because I'm not a CPPer as a therapist, but I love the model. That was the phrase, like, don't play around. Like, basically, like, if you play around, you're gonna die. So play equals harm, on a good day, right? And so yeah, so they have to learn how to play. And so it's not just a big thing that I love about CPP. It's not just for the kid, it's for the caregiver too. I'll give you an example from PCIT. One of the homework assignments we have in phase 1 is you have to do 5 minutes of like non-directed play, like every night, every afternoon. Like you have to be like 8:15 on the dot, but like after dinner, before bedtime. No, you can take away anything from the kid, but not that. Now, if in the play they like sock you, then you say, because you hit mommy in the face, play is over, and get ready for the tantrum. But short of that, that thing is sacred. Had a mom, former foster kid, a lot of these families, and we were really early, like session 4, I think. And mom calls me on a Wednesday. And so fired up. It's about 4 o'clock. She's like, I ain't doing the damn special time. I ain't doing the mother like and here's why she's so mad at me, because her son ripped through 5-year-old kid ripped through his school, his kindergarten class, just ripped through it. He was a demon, and she had to call work, she had to get off, so she's pissed off, and it's 4 o'clock now. She has finally time to call me. And I'm saying to her, Mom, made a deal. Day 1, you will do 5 minutes. It's like, he doesn't deserve it. He doesn't deserve it. Like, I'm not saying, I'm just saying what you agreed to. You agree. It's like, I ain't doing it. That's what she's like cussing me out, right? Left and right. I say, Mom, you are this boy's mother, and I will respect your decision as his mother, but as his doctor, as your doctor, 5 minutes I'm recommending. He's like, I'll do it, and hangs up the phone. Thursday morning, 9 a.m. Get a call. Mom, it's mom. She says, Dr. Gomez, I apologize for my use of language yesterday. And I'm like, Mom, it's okay. Not a big deal. It's not the first time I've been cussed out this week. So what happened? And here's what happened. Here's a short version. Ready? Mom, she's like 5 minutes, like minute 1 into, I wasn't really into it, and they're doing coloring. And so they're side by side, and she's trying to practice surprise skills. Got a color. Doing a great job with the color. Drawn dragon. Like she's tried it, but she's phoning it in. But she says about minute, like halfway through our special time, she says her 5-year-old boy puts his color down, looks up, and goes, Mommy, thanks for loving me even when I don't deserve it. And she said, I burst into tears. I'm like, I know. And I said, Mom, do you know why I told you to do that? It's like, it's part of the protocol. Probably like, no, that's weird. That's not why. Here's why. The thing she had said, and I heard her say this many times in intake, I lost my boy. I had a different kid before, like all this happened, all this horrible crap happened, like before all the trauma happened, right? I lost my boy. I lost my boy. I lost my boy. I said that over and over, and I told her something that my grandfather told me. My grandfather was the first person to cross the border. He was, was like wonderful man, and he would tell me, being lost is so very close to being found. And I said, I didn't do that for your son. That 5 minutes is for you. You deserve minimum 5 minutes every day to see your son again. You deserve that, Miss Smith. He's still there. We're going to find him. And we did. We'll find this kid. But until we get there, you at least deserve 5 minutes every day with this kid. That's why. It's not for them, it's for you. It's for the parents. CPP operates almost identical. That learning how to play is for you, Dad. You never got to play. And I hear like my colleague who does a lot of CPP will say she gets that feedback a lot. It's like, I didn't know how fun play could be. Yeah, right. I'm going to my eye. It's like a parent will say, Andre, I didn't know how fun play could be. I'm like, yeah, you never played before. Like you had like 18 years of straight hell on earth. You didn't get to play. Like now you can play. It's so cool to see him come out on the other side, right? It's so cool. We can get that with CPP, PCIT, TFCBT. We can get it with those models. But I think CPP goes at it in a very direct way, which I love about that. I love that about the model. It's such a cool model. And again, it's a solid 0 to 5 one. The added benefit is they're really, really good. I think they excel at incorporating culture, spirituality, ethnicity, diversity. Because for an example is therapists can switch out the toys. It doesn't have to be like, the like Caucasian looking toy. It doesn't have to be even like things that are ordinarily found in Western culture, right? The only thing I've heard complaints about, it can be up to a solid year, but keep in mind, these families are often dealing with generations of trauma. So I think like a year of therapy compared to a century of trauma, I think that's a good deal. I would take that deal. And so, but oftentimes you don't have to say you got to be here for a year. Just say, hey, try a couple weeks of this and see how it's working. We're kind of like car salesmen, like in a lot of ways. It's like, you know what, like Veronica, you look good. You look good in that therapy. That's your color, Veronica. That's a great color for you. CPP is a good color on you, Veronica. Like, yeah, we're a little bit like that, and we realize that. Okay, that's the only complaint I've heard about CPP. It's a lovely model. If you have access to it, definitely use that model for this age. This is kind of the model I lead with this age range of CPP. It's such a beautiful model. The other one I want to talk about is TFCBT. People ask me, well, how will you pick between like PCIT, TSCB, here's a short answer. If the kid is having tons of behavior problems and they're within the PCIT age range, I'll probably pick that one. If you're dealing with like a lot of recalcitrant intergenerational, try like, and it's like just like this gunk, CPP is really good at that. If it's a focal trauma and the kid has a memory, like they're 4 and they were sexually assaulted 6 months ago, TFCBT, no contest. The age range is 3 to 18. And again, it can range from like, 15-ish sessions with your PTSD young kids, 30 sessions with your developmental trauma kids. But it doesn't just target PTSD, depression, anxiety, behavioral problems, everything. We've done it literally everywhere on the planet. TFCBT has been done in the Democratic Republic of the Congo on a dirt floor. I did it in Swaziland, which sounds like a country I made up, but is actually on the northern border of South Africa and is now named Eswatini. We've done it on every continent on this planet except for Antarctica. And in our defense, the penguins really did not like doing therapy. Okay. That's the only reason. But we have like a lot of people all over the planet. One of the stories I tell is I had a family in Texas because I work in Western Texas. They were in New Mexico military. They were coming in for an eval. It takes us a while to get them in for eval, and so they finally got there. And mom says, "Well, Dad just got deployed to Germany, and the kid didn't meet criteria for PTSD. It was based off of a house fire." And I said, "Where at in Germany?" She said, "I think the Frankfurt area." I called Dr. Manarino, one of the 3 developers, Tony Manarino, and he said, where at? I said, Frankfurt. He's like, we got 3 people there. So by the time they landed in Germany, they already had their session set up because it's an international model. And we have international data, which is very important. It's very, very robust in terms of cultural competency, LGBTQIA sensitivity, neurodiversity, everything. We researched the crap out of this. And that's great. So yeah, I agree with that too, Sylvia. Like just getting parents comfortable with using objects in a way like, yeah, ladle can be that Sylvia's right. Parents may not be used to that, especially if they have their own trauma, which most of my parents do. They're like, no, it's supposed to be a ladle. Well, let's imagine, right? Now, it doesn't just have outcomes for kids, because like if all we do is just fix the PTSD and leave it, we don't consider that a success. There's also parental outcomes too. So parents have reduced PTSD, reduced depression. We also have studies that there is also enhanced resilience. And the reason we have that is because we think that, if you learn how to integrate the trauma, you'll also be enhanced with resilience. So it's not just that we lower pathology, we also have research now enhances resilience. The way people ask, well, how do you get that parental stuff to go down? Here's how we do it. Ready? So Miss Andrea, I know that, like you don't need to know how to breathe, Andrea, but Veronica, she's like a train wreck, right? I mean, we can all agree Veronica's a train wreck on Miss Andrea. But so Veronica, she needs to know how to breathe, right? Oh my God, she needs to know. So instead, Andrea, of like making her have homework, we're gonna make Veronica a teacher, and you're gonna pretend you don't know how to breathe. I know you know how to relax, Andrea, even though you cussed me out at that intake session. But you don't need it's oh my God, Veronica. So we backdoor the skills basically. Like through the mouths of babes, right? Like we backdoor all of our skills. And so we have the kid teach the caregiver. The caregiver is in, especially with your littles, the caregiver is in every session. So there's even we have even manuals for this too. Those of you who are clinically minded. The way it looks, it's called the practice acronym. You'll see if you see parent, think caregiver. No, it doesn't have to be a parent. We've used aunts and uncles, foster parents, adopted parents, inpatient floor staff. Teachers have literally saved our kids' lives in this model because we have to use them for the caregiver component. CASAs, CPS, sheriff's deputies. We use nurses. We use everybody. It's a 3-phase model. We never talk about the trauma first. That's called flooding. We have to give them skills and education, just like you saw on the previous slide for all effective trauma therapy. Then we can talk about it. That's only if they have a memory. So if they don't have a memory, you might pick something like CPP or PCIT. There's other models too, which I didn't mention, that are wonderful, like ARC, Margaret Blossing, Christine Kinnerboro's model, stands for attachment, self-regulation, and competency. Awesome. And the only reason I didn't mention is space. That's it. I mean, it's a beautiful model. And then you can't have a party without ice, right? And so we want to also have the caregiver hear this. Now, for kids who are not neurotypical, and this is what it looks like for our kids with autism, but also our very young kids, is instead of third, 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 it's half, quarter, quarter. But it's still the same model. And it may take you more sessions. So I do a lot of work in TSCBT. I'm one of the national trainers. And I'll get a therapist, really good therapist. They'll say, Dr. Gomez, I could only get like, 35 minutes. And I'm like, Jenny, how did you get 35 minutes with a 4-year-old? I only got 15 with mine, and I was hustling, and then they were in La La Land. You must be an amazing therapist, Jenny. And that's not me being sarcastic. So we recommend like 30-minute sessions max with these kids. If you're doing something like TFCBT, because you're not going to get a 50-minute hour with a 5-year-old or a 3-year. Like, there's not going to happen. If you do, email me, because I need to know how you did that, because I've never been able to successfully do that, and I train people to do this. So you get 15. That's awesome. You're doing great work. Okay. And this is the actual manual we have for preschoolers. It's 3, 4, 5, 6. Michael Sharinga, who's out at NOLA, developed this in conjunction with Judith Cohen, one of our developers, Judy Cohen. This is not like TFCBT. This is TFCBT. This is what it looks. This is actually a time capsule, by the way, this particular book. The original name of the model was PTSD treatment for sexually abused preschoolers and a non-offending caregiver. Doesn't exactly roll off the tongue, right? But that's what it was. We worked with 3, 4, 5-year-olds at the beginning of this model in '96 because we thought, why not catch the PTSD at 4 rather than 14? Now it's used with much older kids, but that it originally started, and still the nucleus is with younger kids. So this is a model that was used for this age range. Now, a lot of people will say, like, well, what does CBT look like for young kids? So I'm going to show you the best CBT I've ever seen. I think this is a 4-year-old girl. It might be like 3.5, but this is the best CBT I've ever seen for a 4-year-old kid. Ready? Everybody ready? Here's what it looks like.
In your potty. Poo-poo in your potty.
We gotta tell mommy when you need to pee. Tell mommy when you need to poop. Tell mommy when you need to pee. Tell mommy when you need to poop. We need to pee pee.
On your potty.
We gotta poop poop.
On your potty.
We gotta pee pee.
On your potty.
We gotta poop poop.
On your potty.
You gotta tell mommy when you need to pee. Tell mommy when you need to poop. Tell mommy when you need to pee. Tell mommy when you need to poop. We gotta pee pee.
In your potty.
In the potty, gotta poop poop.
In your potty.
In the potty, gotta pee pee. In the potty, gotta poop poop.
In a potty.
Tell mommy when you need to pee. Tell mommy when you need to poop. Tell mommy when you need to pee. Tell mommy when you need to poop. And then you get a prize. And then you get a prize. And then you get a prize.
Yay,
And then
Janaea!
you
Everybody
get
their
a
hands.
prize.
Okay, few things about that clip. First, that is the cutest freaking kid I've ever seen, and I will have words with anyone who disagrees with me. That's just the cutest kid in the world, okay? And so, yeah. Second, there was no triangle there, no cognitive. Why is that CBT? Well, the reason is there's an action, there's a cognition, there's a lot of emotion, and there's a consequence, like, and then you get a prize. That's what it looks like for kids this age range, okay? Any of you who have kids or have had young kids at some point, I will guarantee, I can prove to you right this second, you've done CBT with your kid. Ready? I'm going to prove it to you definitively. Clean up, everybody clean up. Right? You remember that one, right? I'm not going to baby shark you. I'm not that cruel a person, but you've done CBT with your kid. We call that a mantra, right? That's what it looks like. CBT is actually much easier in younger kids. It's like really easy. And so like that's what it looks like. It's very easy. Like when we do skills, we make it very visual. Like this is one we did with one of our younger kids who was not neurotypical. And when your brother misses the bus, he has a thought. Let's call mom, and you get. This is not the brother, by the way. This is just a stock image. Our kid had a cat. He loved his cat. But when you miss a bus, you act like Morris, and you have a little alarm in your head, and it signals danger, danger, and you can't hear anything, so that's why you cry. Okay? So we can do this very easy, very visual, very simple way with kids. We don't have to use language, honestly. We don't have to use words. I like Dr. Osofsky's quote, one of our big dogs at the network: kids show stress, but they also show resilience. Now, the very last thing I wanted to do, and then we'll go to questions, save a couple minutes for that. You're not getting out of secondary trauma stuff, okay? Because all you do very tough work, and we are in the age of COVID. Congratulations. And so, because you also have amygdalas, right? And so, here's Dr. Brian Miller is the developer of the model I'm about to reference called CSERT. He's gonna be with y'all a little bit later in the sequence. He taught me all of this. If you get a chance to do his training, jump at it. Anytime he's Dr. Brian Miller, Brian with an I. You can type in Brian Miller on Amazon and get his manual, the manual for CSERT. But here's the very short things I'm going to go over. Please do not put this in the chat box, but I'd like you to answer this question for yourself, like on a piece of paper on your phone notes. If your job is so hard, stressful, I don't know if you're aware of something that happens a couple of years ago, you may or may not be aware, called COVID. Yeah, you could die as an educator. You could die. Like, I don't think any of y'all signed up for death in your job. Why do you keep coming back? And in CSERT, we call this a conscious narrative. And yet January 5th, Dr. Miller will be with y'all. And so this is what we call a narrative in CSERT. And I'm going to give you your narrative from the perspective of somebody who doesn't do your job. You're a crazy person. That's what you are. That's why Sylvia's friends and family are sending Sylvia like MBA applications. It's like, oh my God, Sylvia, you'd be so brilliant. And Sylvia's like, Mom, I got a job. Why are you sending me law school? Well, because Sylvia's friends and family think that she's an insane person and are trying to save herself from her insanity, right? And so a big rule in CSERT is you don't define your narrative, people will define it for you, usually not in the way you want. And so we spend a lot of time about what we call a career sustaining narrative rather than a career defeating narrative. Okay. We'll take a career surviving narrative too, if that's all you got for the day, and that's fine. But the first conversation I have with my trainees is dare a decade. You do this job 24 hours or 24 years, you got my deep respect. No questions asked. So let's reframe your narrative, right? So I don't know if anyone knows the poet Johann Wolfgang Goethe. Anybody not have a girlfriend? No social life, can't get a date, just me. Cool, thanks, appreciate that, guys. Thanks for that. But he's a German poet, and he has it translates into a phrase, I think it's in Sorrows of Young Werther, translates into, it takes an incredible person to step inside the pain of a stranger. That's what you do, don't y'all? Like, Jackie doesn't know these kids, right? Dolores, they're not related to Dolores. Pretty sure, like, these aren't all Cynthia's, like, friends and family. You step into the pain of strangers. That's an insane thing when you think about it. So you do that 24 hours or 24 years, you have my respect, period. No minimum tour of duty. When I started learning this, I was a licensed psychologist when I started learning this, and which the equivalent would be an infectious disease board certified physician who doesn't know how to put on their PPE. blows me away. But that's the norm in training programs. This is kind of a fringe thing. This is an elective course, if anything, right? The current program, by the way, if you're a social worker, you're doing better than any of us, by the way, training wise, training program wise, but still got a lot to go. But by far, you'll get a gold star for that. When I did these trainings, Dr. Miller, we talked about this in his January talk, but here's what they look like. I would be in a 2-hour training on secondary trauma, and here's what's the breakdown. 90 minutes of definition, secondary trauma, vicarious trauma, compassion fatigue, more, and then 30 minutes of what I call lowercase s self-care, like take a bubble bath or get a cupcake. In the CSERT model, we are pro cupcake and pro bubble bath. We just don't think that's going to cut it for you for what you're dealing with. So this is the only thing we're going to do. We're going to only do a minute on definition, and that's it. Here's the only thing you need to know. Secondary trauma, vicarious trauma, I will use those interchangeably, but they're different from burnout. And here's all you need to know. Secondary trauma, I also refer to it as vicarious trauma, is a virus, and burnout is an immune deficiency. I'll say that again. Secondary trauma is the virus, burnout's the immune deficiency or compromise, which explains a lot, right? So, hey, Dolores, how do you feel? I think I feel okay, Michael. Am I repressing? Do you feel all right, Dolores? Yeah. Maybe you're fine. Maybe Dolores has a great psychological immune system. I don't, but maybe she does, right? But even if Dolores has that, she's going to find a virus that's going to overcome her immunity. That was what COVID's been all about, right? And so our starting point in CSERT is you will get the virus, you will get the immune compromise, you will get both simultaneously. That's it. And that's our starting point. We're not going to stigmatize that. We're going to normalize that. By the way, you realize we're one of the only fields that gives people crap for that, right? You've never heard the following. You know, I saw Veronica crying in her car in the parking lot. That's an OG provider right there, man. Yo, Flores de Leon, man, that's old school right there, man. She's the best I've ever seen. No, no one does that. Veronica slightly has a tear in her eye. Veronica, are you okay? Do we need to send you to EA? Like, can I emote for 30 freaking seconds? Can I like I had a hard day? Can I just emote? Like, why, no, that like my uncle is a plumber. He comes home smelling like literal feces, and the reaction from my family is, Theo's a man. He did man's work. I'm like, Theo, you freaking reek. Take that. But that's a point of pride, is because he smells like a septic tank. He's a man. And Theo did man's work today. Like, yeah, that's the reaction. We don't do that with our field, right? That's bizarre to me, right? And we call that out in CSER. Now, the only other thing I'll talk about definition, and I'm going to do one last thing, and then we'll go to questions, is it looks like secondary trauma. Secondary trauma looks like PTSD, what we just talked about. Nightmares. It's never that kid you think, right? You think Cynthia thinks it's going to be the 5-year-old, it's the 12-year-old. Avoidance, let me know. Like, hey, Marissa, you there? You okay? Yeah, I'm good. Yo, Marissa, we lost you for a second. You all right? I'm 5x5, Gomez. I'm square. All right. Shitting on yourself. Ruth shoulds on herself all the time. I should have done this, and I should have done that, and I should have been there. And if you've ever ripped your partner a new one for no reason, congrats, you're hyper aroused. Sweetheart, do you want Chinese? Why does it always have to be Chinese? Okay, Italian. We'll never eat Chinese. We'll never talk to anyone who's Chinese. Yeah, if you did that, congrats. You're hyper aroused. You weren't crazy. You were just hyper aroused, right? These other ones are very specific to secondary trauma. General disillusionment. You know, folks, I've been doing this job for about 20 years. Kids die every year. System more freaking broken than it's ever been. No one gives a crap about our kid. Alienation. Yo, Gomez, man, you might want to talk to someone about that. I can talk to anyone, Deidre. Okay, I'm packing off, Michael. Now that gazelle cut from the herd, alienated from the herd, that's you. This last one, I had a psychiatric nurse explain it better than I've ever heard in anywhere in my career. She said, I get my 8 hours every night, but I wake up and my soul is tired, and I don't know how I'm going to deal with this. So how do we cope? Here's how I cope. Has to be 180 proof, folks. Is it bad that I call all alcohol Pingo bye-bye juice? That's healthy, right? I mean, that's part. So Jack Daniels is the official sponsor of alcoholism in the Gomez family. We have sent more Jack Daniels kids through college than any single American family. We should get like breakaway sweatpants or something, right? So I was raised by my uncles, my mom's brothers, who are 3 Vietnam Marines. And my Theo Victor, who I spent the most time with, never did not see him without a bottle of Jack. And that was it. And that, so when I started learning this, the spectrum I teach, and Dr. Miller will take you through this if you're in his talk, I learned can't take the heat on the opposite end, that is CSER. And in the middle, we'll talk very briefly about self-care and trauma stewardship. But can't take the heat is the Jack Daniels approach, right? And it didn't seem weird, right? It didn't seem weird to me. The first job I had in mental health was at an inpatient unit called Sunrise Canyon. And as we know, all inpatient units and residential treatment centers are named after salad dressing. Sunrise Canyon, Pleasant Acres, Shady Valley, like we could roast a rotisserie in that one. Yeah. And so not the first month I'm there, but the second month, I worked swing 3 to lights out, an hour after. A guy my age at the time spent an hour before lights out telling me the graphic details of physical abuse history by his father. I'm checking out, clocking out, I'm glazed over. Dissociation is the term for this, right, clinicians? Not my boss, but a senior staff. The guy had rank on unit. He looks at me as I'm clocking out. He goes, "Yo, Gomez, what's up, man? What's wrong with you?" And I said, "Yo, man, this dude got the beat out of him. Dude, what do I do with this, man?" And I'll never, he gave the can't take the heat wisdom, paradigmatic can't take the heat recommendation. He says, "You think you got it tough, man? You get beat for 10 years, walk it off, be a professional." Which didn't seem weird to me, right? Because again, I was raised by 3 Vietnam Marines. I couldn't complain about anything. Like, "Yo, Theo, man, I had a hard day today." "Oh, yeah, mijito? Send the name 68. Were you there?" "Theo wasn't born in 68. Marines don't make excuses, mijito." Like, never mind. It's like rock, paper, scissors, Vietnam. You can never one up these guys, right? And so none of this seemed weird, right? That just seemed like that's how it is, right? Just suck it up, buttercup. Like, you know what? You want a cookie, man? It's a tough job. Deal with it. That just didn't seem weird. I was raised by 3 Vietnam Marines. That seemed pretty consistent with my life experience, right? I'm also a cisgender Mexican guy from West Texas. We don't know we have emotions till we're 18 and our girlfriend tells us. That's what it is. Like, so I see that Sarah McLachlan commercial with the dogs and cats. It's not an analogy because I'm allergic to cats. No, corazón, that's triste, that's sadness. Like, I ain't been sad since I was 8, but not be straight. Come on, right? Yeah, and I know it's stupid and it's dumb, and I'm working on it. It's toxic masculinity. I'm trying, Carmela. Thank you for appreciating that. And so, yeah, that didn't seem weird, right? That's a very. I'll give you the subtle way. Here's a subtle way. So if any of you, let's say that I'm just let's say like Sylvia's been doing this job for like maybe between 5 and 10 years. This is the subtle way. Okay, so Sylvia, I've been in this job for about 20 years. And here's kind of what that means. So, Sylvia, I've been doing this job for about 20 years, which means I'm kind of better than you, Sylvia. See all those books? Read them like a doctor, like kind of awesome. Like, yeah, that's the implication is between me and the person who's been doing it less than 10 years, I'm just tougher because I've been in the game longer. Here's what our literature shows. Between me and somebody who's been doing this job 5 years, the person who's going to be better is Sylvia. Here's why. 2 reasons. One is called cognitive flexibility. Hey, Sylvia, you don't know anything. I know. Yeah. Like she's going to be more cognitively open. There's no more recalcitrant brain in a 10+ year PhD. Okay. And that's the truth. And the other reason is I'm not starting at 0. Sylvia's starting at 0. I'm starting at -10 because I did a decade of Can't Take the Heat. So even today, even though I trained this and teach this, I had a kid who they did not complete suicide. They didn't even go inpatient, but I was out the week that my backup was doing, and he did fine with it. But she was suicidal and she wanted to kill herself. She didn't, and we got it resolved. She didn't have to go to the hospital. But here's what I did for 30 minutes when I found this out. Ready? Hold on. Are you that stupid, Gomez? You're a damn DBT therapist. You're a national cleaner. How the hell have you not get the? Yeah, did that for 30 minutes. So one of my accountability partners, that's a term we have in CSER, says, "What you doing?" "Nothing." "You're beating the piss out of yourself, huh?" Like, yeah. Because I did that for 10 years. Sylvia just hasn't done that for 10 years. So she's going to be better. She's starting at 0. I'm starting at -12. So I got to catch up. By the way, those of us on the Zoom, you're 20+ years in this, being older, things get worse. That doesn't surprise you. Come on. Like, in my 20s, like, how'd you throw your shoulder out, Michael? I was rock climbing. Now in my 40s, how'd you throw your shoulder out? I was reaching for a jar of jam. It was eye level. I wouldn't even reach out. I just threw it out. I had 3 months of physical therapy. Yeah, yeah. You get older, things get worse. That's not a surprise. Okay. Now the next thing you run into is self-care. And we here's our position on self-care and CSER. Dr. Miller will talk more about this. If you're doing self-care and it's working, keep doing it. If you're not, don't do it. If you like yoga, do yoga. Don't like yoga, don't do yoga. There's an empirical and a conceptual reason why we think self-care is very high risk with very low reward. The empirical, when Dr. Miller was creating the model, he could only find one study on self-care. It was done on medical students. And here was the study. Control group, self-care group. In group 3, they literally said this: do something. Hey, Santana, do something. That was it. And here are the results. The control group, no change. The do something group got better, but it wasn't statistically significant. The self-care group, it got worse. Here's why. Marissa, did you do your self-care? I didn't do my self-care like I did in my case notes. I didn't do anything. Yeah. I gave one more checkbox on an already stressed out provider, didn't I? I just made Risa's life harder. So our position in the CSART Trainers Network, in the National Traumatic Stress Network Secondary Trauma Committee, and at the Secondary Trauma Consortium run through UK, Kentucky, is the following. Secondary trauma, while being an individual impact, is an agency institutional responsibility to address. It has to be done as, you can't just give them self-care and expect you to do it after work. It's not going to work. Part of the reason I may not be at the site I was at previously on the East Coast is I said this during the leadership meeting, that what I just said to you, and I got some like, I don't know, Dr. Gomez, and that's not the, here's ready for me to step in it. Here we go, because I'm not a political guy, and it doesn't hurt me sometimes. So here's why. I said, okay, well, I understand your hesitation, but that's odd because that what I just said is the exact policy you have for COVID-19 at your hospital. It is an individual impact, but an institutional responsibility to address. Right? And yeah, that's not a weird concept for the hospital, for especially hospitals. It's an like, yeah, that's why you have to do all those freaking fit tests, right? That's why you have to do all those webinars because, like, yeah, the hospital is like, yeah, Sylvia can do some stuff about COVID-19, but it's actually our responsibility to help her, not hers to do it after work. Hey, Cunningham, figure it out for your team. No, we have to figure it out. Sylvia has to do some stuff. That's it. It's secondary trauma is the same way. Self-care doesn't like yet just in my agency that I just finished working with, they bring you a taco truck once a month. I love tacos. Please keep bringing that truck. I don't think it's going to fix the 17 suicidal adolescents I saw that month. Don't know. But please bring me tacos. I like tacos. And here the conceptual reason, and I'll finish off here. Ready? Second to last thing. Let's say that Carmela is my supervisor, and I knock on her door and say, hey, Carmela, can I check in with you? Yeah, Michael, what's up? Remember that 5-year-old we saw last month? Yeah, the sexual trafficking victim. What that was really tough one, Michael. How are you doing? Yeah, Carmela, I'm gonna be honest, I'm not doing well. I'm not sleeping, I'm having nightmares. That little girl's face pops in my head when I don't want it to. I'm angry. Oh, but my mom's head off. Just I don't know what's going on, Carmela. I'm kind of freaking out. I don't know what to do. And Carmela, as a good supervisor, says what I said literally for years to supervisees. Ready? Michael, that's a very common thing we deal with here at our agency. It's just nothing about you and everything about the horrific awfulness of trauma in children. Like, tell you what, Tuesday, take Wednesday, Thursday off. Dana won't even know. She's not even here. Okay. Checked out. Okay. Go for a run, hang out with your mom, play with your dog, watch a movie, just recharge your battery. And I'm sure you'll be fine by Friday. And compared to Suck It Up, Buttercup, it is enlightened. So if you're doing self-care, you are in a better position, I swear, than if you're doing Can't Take the Heat. Here's the conceptual problem. This is a really important part in CSER. Let's say you are a licensed clinical social worker at University of California in San Diego. And you have a 20-year-old sophomore named Janie come into your clinic and say, Miss King, ever since my ex raped me, haven't been doing well. I'm not sleeping. I'm not, having nightmares. This face kind of pops into my head. I am angry all the time, Miss Stamps. I bet my roommate's head off. Veronica, I'm kind of freaking out here. Marissa, I don't know what to do. And you, as a licensed provider in the state of California, say the following to Janie. Janie, that's a very common thing post-sexual assault. It says nothing about you and everything about the horrific awfulness of trauma. Look, tell you what, it's Tuesday. I'll write you a note. Take off like Wednesday, Thursday, go for a run, hang out with a roommate, play with your dog, watch a movie, just charge a battery. I'm sure you'll be fine by Friday. Does it sound now? I think it's a licensure violation in California, honestly. And I think it is. And the full day, it's actually like multiple day training, a full training that Dr. Miller and we do. We're part of the trainers network for CSERT. I drag it out. I'm going to give you the very short version for time's sake. PTSD criterion B, C, D, E, and F, Michael and Janie and San Diego are identical people symptomatically, correct? If we put Michael and Janie under a functional magnetic resonance imaging machine and scan their brain, they would light up identically, correct? So why do we treat them so different? And in the full training, we drag this out, but I'll give you the short answer just for time's sake. Here's the technical answer is criterion A. You want the blunt answer? Here's the blunt answer. Dude, it's your job. You get paid to do this. You get to school for doing it. I mean, won't put a gun to your head, Cunningham, to walk in that room. And then be honest, Dolores, you kind of put yourself in that position. What were you wearing, Laura, when you did there? It's victim blaming. Super subtle, almost never intentional, but it's victim blaming. And it's victim blaming in a way, way, way more insidious way than you might think, even than what I just described. Let's say I tell Michelle to do self-care as her supervisor, and she does it and it doesn't work. At this point, you can tell I'm highly sarcastic, but this next part is not sarcasm. The best case scenario for Michelle when self-care doesn't work that her supervisor told her to do is this. Michael's an idiot. He doesn't know his job. That really is her best case. Here's what Michelle, and I'm guessing all of you are more likely to do. Ready? Well, Michael's, he's like, seems like a nice guy. He's really smart. I mean, he's literally an expert on this stuff. I mean, he wouldn't give me something bad to do. So I guess the problem is, Michelle, I'm the problem. I'm horrible. I shouldn't have done. I never should have done. Right? It goes into self-blame. That happens with anxiety, depression, traumatic stress, and I never see it. Michelle never sees it technically. So we consider self-care as high risk with low reward. So if this is all very new to you, I would highly recommend getting the book, even if it's not, get the book Trauma Stewardship. It's by Laura Venner-Lipsky. You can get it on Amazon. Just read the cartoons. It's lovely. CSERT is what Dr. Miller talks about. He'll talk more about that in January, so I won't go into that as much. But CSERT is not a self-care model. CSERT is a way to change how you're interacting in real time. And it works off two pillars of like reducing trauma. We steal that from PTSD literature, but also enhancing your engagement. Because it's you like we don't mess with your stress. We don't ever tell you to calm down in CSERT because we don't try to Taylor Swift you in CSERT. Okay. And also, have you ever been told to calm down when you were pissed off? Yeah. Someone tells me that, like someone tells one of you that, and I'm there, I'll go to bat for you. Like, like you can throat punch him and I'll say, yeah, Marissa and me were just talking. He started choking. That's weird, huh? Bizarre how that happened. I don't know, me and Marissa just talking. Yeah. And so, yeah, but we think that your most engaged days are not your low stress days. So think back to like you've had tons of crappy days in your job, but think back to one of those days where you were on fire, like, man, I'm freaking nailing it. Wasn't a low stress day, was it? It was moderate to high, but you were in the zone, right? Did that. And CSERT wants to draw on that. That we're taking from the field called positive psychology, peak experiences. So this was used with high-level athletes and high-level performers. And so we're melding those in. Dr. Miller will give a whole talk on that. I highly advise you to attend it. It's a great, but he's just a very brilliant man, and he's also a nice guy. The very last thing I want to say before we go to your questions is, and I'm going to kind of skip to the end, is I want to very quickly give you my philosophy of therapy and the most powerful therapy tool I can give you. Ready? Here it is. Fast way I know how to describe this, the time we have left is, I was asked to do, it was Hispanic Heritage Month, and one of the people here in West Texas, a school counselor, said, we need a Hispanic doctor to talk to the fifth graders. I'm like, I'm not that kind of doctor. They're like, freaking fifth graders there. And I'm like, okay. So I go, and I'd say I'm a therapist a lot. These were nice kids. But by the way, it wasn't a fifth grade classroom. It was 50 fifth graders in a gym. And I followed a firefighter. Okay? He's like, he had an axe. He runs in the building. I'm like, feelings, right? But they were nice kids. And so I say I'm a therapist. And I say, any questions? A little sharp cookie in the front row. I was like, I got a question. I got a question. I got a question. What's your question? What's a therapist? Freaking little Barbara Walters. Like, how do you answer that, right? He's like, well, you got to graduate college, take the GRE. You can't say that to so like, I had no idea. Nothing. And so out of thin air, here's what I pulled, and it's my philosophy of therapy. Ready? I said, all right, who here seen Dumbo? All the kids like, we seen Dumbo. We said, like, I point to the little girl. What in Dumbo can you say loud enough where all 50 people can hear? What is the feather? What's the feather in Dumbo? Here's what she says. When Dumbo's friend gets a magic feather that helps him fly. But it's not a magic feather. Best friend lied to him. It's just a feather. He didn't know how to fly the whole time. He didn't need a feather to fly. He could fly the whole time without a feather. He really didn't need it. His best friend lied to him because he could fly without the feather. Therapist. That's it. That's all I am. Didn't need me, Dumbo. Fly the whole time without me. Maybe to get off the ground that first time. I don't really buy that, but no. Outside of this job, I am Matthew McConaughey from True Detective season 1. I'm a nihilist. I just don't. I think we're all doomed. We're all doomed. One of us is doomed. Time is a flat circle, and we are mistaken evolution. That's me normally. The only reason I have faith in the human condition is my kids, because not all my kids obviously. I think we're with teens because they reflect my worldview. But like my little kids will be like, Miss Andrea, I think people are good. No, they're not. People aren't good. They're evil. Not all of them. Most of them. Like this is my conversation like an 8-year-old. I'm like what? And I'm like, how are you still wanting to connect? People are horrible. And they're like, well, some of them. And my basic opinion is, man, if you're 7 and you're showing up for work, I'll be there too, man. I'll clock in. I got to, man. I can't do any less, right? It's like, all right, kid, you showed up for work today. I'll show up for work today too. Okay. Now, the best kind of therapy trick I know, the most powerful therapy tool, I'm gonna give it to you now, and then we're gonna go to questions. Ready? If you're talking to family, you're talking to a kid, you have no idea what to do, and you're lost, you're like, I can't do the pride skills. I don't know how to do that triangle thing. I want to do the. Here's what you do. This is the most powerful thing you can do by far. Ready? Ready for it? Here it is. That was like 15 seconds of silence. It was killing us. Yeah. Don't say anything. Just be. What's that like Brene Brown quote? You know, when people are in that big giant pit, it's not what you say, it's a connection. Just be there. That's it. You showed up there. You're there. That carries a lot. That carries a weight. As a person with trauma, you remember like who screwed you over and who was present with you. Like, yo, man, Miss Bowman, she all right, man. You know, she was all right, man. You know, nobody gives about me in the system, but Miss Bowman was all right. They remember that. They always do. You don't forget that stuff. And the very, 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 very last thing. Do you know what is the greatest gift anyone can receive in his or her lifetime? The greatest gift we can receive is the chance, just once in our lives, to make a difference. Caltrin, everyone on this Zoom, do all of you really truly understand how much you made a difference? All of you made a difference for enough for 100 lifetimes. Dr. Strange, speaking to Peter Parker. And last but not least, your zombie killing name. Okay, so I have been the Mad Double Tap. I appreciate your time. I think we got a few minutes for questions. I will pass it back to Crack Crazy. Okay, Dana, your zombie killing name is one of my favorites. I will be honest with you.
Hits just right, doesn't it?
It's so perfect for you.
Love it. So I'm already seeing a ton of thank yous in the chat, but you actually, Michael, do have time for questions this time. So
I know, I'm very proud of myself.
I'm amazed and really happy about that. So this is a great opportunity. If you do have time, if you do have a question for Dr. Gomez, feel free to put it in the chat now. We'll take a couple before we wrap up. Whether it's about the initial content on all of the material you covered, the final material on how to take care of ourselves, certainly go ahead. And if you've got questions, this is a great time to put them out there.
I
I did
a question too. So I think I try to get all of them in the question in the chat, but if I missed anybody, I wasn't ignoring you. I may have just missed it. So please feel free to put it back in there too.
And we'll kind of keep an eye on that. And I did absolutely promise you all a short 2 hours with a lot of content. And I think we absolutely delivered on that today. If you're somebody who's seen this twice because you needed to see it again, that's fantastic. I know that I took away a lot of new things today. I'm loving this, Ladidra. Thank you. Best webinar ever.
Ladidra's the big bullet, and that just makes me very happy. That's a great one too. Like y'all have some Captain Blade, y'all have some amazing zombie killing names. So.
And for our newest great point, the recording along with the slides, and Dr. Gomez talked about a lot of resources today, and we're going to send you an email that has all of those. And then 2 weeks from now, we're actually going to send you another email with even more related resources. We just don't want to overwhelm you all at once. So you'll have all of those within 2 days. You will have access to the recording, Monica. We'll have that in the email in about 2 days straight to you. And then it'll actually be, if you want to see the previous version of this training, and I assure you everyone is different, but we do keep archive trainings on our website. So if you were to go out to the registration page for this training, you could actually see a recording right now. But if you can wait 2 days, you'll be able to see this one. And I'm just checking if there are any questions. I still do not see any content related questions, which means I have to assume you covered everything this afternoon.
And you just have a great crowd, dude. So they've been very interactive. I really appreciate them doing that. So, and also their zombie killing names are some of my favorites in any presentation.
We really appreciate having you again. I feel like every time you come back, you have a new example that really helps connect people with what they're trying to learn. Like everything is very concrete and relatable, and we are often fascinated. You often seem like you're taking an arc and, you know, as facilitators, where is he going? And you always bring it back. So we appreciate that.
Thank you. And then I will answer Teresa's question. Their question was, when is it baby PTSD or autism? That actually is part of what I do for my research, for my field of interest, Teresa. So I love that question. The very short answer is, one of the tells is that PTSD is usually very context specific. Autism is usually very pervasive. And again, autism is be under pervasive developmental disorders, which is still a nice way to think of it for that question. My go-to examples I had with child welfare, I have to do this a lot. Well, Teresa, he has autism at school, but not at home. And I have to explain to the worker, autism is not like my uncle's left rotator cuff. Like, Teresa, when it gets cloudy, my autism flare right up. There's in this ledge, see a little autism right here in my shoulder. Like, no, it's perfect. It doesn't, it's not content, but like now it doesn't get like kids with autism, they'll get exacerbated, like their rocking gets worse, their like, their tics may get worse, but it doesn't create from whole cloth. You often see baby PTSD just come out of nowhere and then go away again. It'll flare up and go down, whereas autism will get worse and better because they have trauma. We're still working on, one of my research interests is working on tool like assessment tools, guidelines for exactly how to differentiate traumatic stress and ASD. It's one of my kind of pet projects. And so another good thing to think of is for kids who are not neurotypical, our PTSD metrics aren't the best metric. Our adaptive behavior metrics, like, can they put on their clothes? Can they like, play with toys, like things like that. So that's a great, hopefully that addressed it a little bit. Great question.
That was a good question. Thank you for really sort of elaborating on that as well. We do have a couple of other trainings that are related coming up. We have not put registration out yet, but we will see Dr. Megan Lukasik from our very own Rady Children's Hospital in February, talking about differentiating trauma from other developmental disorders. And I know we also have the recording from the training you did on IDD this summer. So we've got some options if you want to dig a little bit deeper there. As you see, we put the survey and the certificate of attendance in the chat. You need to finish the survey. The certificate is at the end. If you have any trouble, just email us. I really appreciate all of the I guess we don't have any panelists today. We have, Michael, you feel like a panel.
That's the best compliment I've ever been given, Dan. Thank you. Like,
all
you
three
feel
of
like
you
you're
were
5
great.
people. Like,
Our panelists were fantastic today.
Awesome. Yeah, I could have worn a hat and just like taken it off in the middle of it. Yeah, and that
would have been great. So no, we really appreciate your time today. We also appreciate all of you who joined us today, participated in the chat, had great questions, were super engaged, and we look forward to seeing you again at another Caltrin training very soon.